Hi everyone, my name is James. I'm going to be talking to you about diabetes and humanitarian crises. This is a pre-recording, but hopefully I'm around for the Q&A. So that is a picture of when I was in Lebanon in Majda Anjar as part of MSF. So a little bit about me. I run a group called Voices in Action, or Via Diabetes. I used to work for the WHO, something called the WHO Global Diabetes Compact. I've also done work in the Eastern Mediterranean office of the WHO. I've done some work with Doctors Without Borders, Médecins Sans Frontières. I've worked in other NGOs. In the UK, I'm on the board of the Global Alliance for Chronic Diseases, which is a research alliance. I'm also a person living with type 1 diabetes and a couple other conditions. Today, I'm actually in Marrakesh. So today's talk, I want to establish some diabetes 101 stuff. We're not going to get extremely technical, but I find it's helpful for people who are not in the diabetes world to kind of understand the importance of some of the medicine and biomedical science of it. We're going to talk quite explicitly about the problems that refugees with diabetes are facing, the short-acting, the medium-term, and the long-term. Some experiences that I've had and that people in my community have had. I'm going to highlight a couple different studies and going to highlight a couple different initiatives which you might find quite interesting, and then we'll go to Q&A. So diabetes is many different types of diseases, or more accurately, many types of diabetes. So you've got the type 1, type 2, which most people are familiar with. So type 1 is about 5% of cases globally. It is characterized by the complete absence of insulin or progressive absence of insulin, caused some form of pancreatic beta cell destruction, generally autoimmune, but not always. There's different theories. The prevalence of type 1, like all forms of diabetes, is generally going up. And there's a couple of different theories about that. The takeaway from this is that if you have type 1 diabetes, you need insulin. So I've got some insulin here. So I'm on, basically I take this in the morning. I'm not going to say the name because I'm not getting paid by the company, but usually characterized by a basal or a background insulin treatment and then a mealtime based treatment. And there's some other forms as well. When we're talking about refugee contexts, things like insulin pumps are usually quite rare, but not, not unheard of. Type 2 diabetes is the more common. You're going to see a lot of underdiagnosis of type 2 diabetes, but generally it's 85 to 90% of the cases globally. You can think of this as progressive insulin resistance, so the insulin that is being created by the body is progressively less effective, which generally creates the body to create more insulin to try to get the blood sugars down, and can eventually lead to pancreatic beta cell exhaustion. So basically, the body burns out of its ability to make insulin, and in case you're de facto type 1, except for now you have to take large doses of insulin. There's some newer research around what is, I guess, WHO doesn't re-recognize this, but some interesting research by Dr. Kat and colleagues out of Cameroon as well as the UK on type 5. So the WHO classifications, I believe until the 90s, recognized it. So this is a malnutrition-related diabetes. So it's a diabetes brought about by either chronic undernutrition, and there's also some debate in the literature whether or not there are specific phenotypes in certain African populations. But it's an interesting piece of literature that I won't go too much into about because it seems like the science is still being debated. Gestational diabetes, aka pregnancy-related diabetes, which is when you start having high blood sugars in pregnancy. This is sometimes transient, i.e. will go away after pregnancy, but sometimes it doesn't, and then it evolves into type 2, but then also people who have gestational diabetes are at a lifetime risk. And then we have rarer forms, which we're not going to talk too much about. So when you have diabetes, your body is harmed through hyperglycemia, i.e. high blood glucose. So there's a couple of different biomedical theories around that. I prefer Brownlee's unifying theory. It could be because, my schooling is a bit old, but basically there's reactive oxygen species damage, which hyperglycemia causes, which affects the endothelium of the body. So your blood vessels, especially your small blood vessels, are badly affected, which leads to occlusion, which leads to things like kidney failure, retinopathy, blindness or partial blindness. Diabetic foot ulcers are very common. Actually, diabetes is the largest cause of amputation worldwide by a lot. more so than anything traumatic, landmines, anything like that. Uh, Sexual dysfunction, both in men and women. Mental health is probably under recognized as an issue, but the depression rates are much higher in people living with diabetes. There's also specific forms of disordered eating, especially on people who take insulin, as insulin is related to the ability to feel hunger. So you're effectively giving yourself the ability to not feel hunger. That's a broad oversimplification, but there are specific disorders around things like diet bulimia. The other thing to keep in mind in a refugee and humanitarian context is diabetes is inherently immunosuppressive. So the WHO ran a couple of different campaigns. I believe there's also joint guidelines on diabetes and TB. Now, I'm trying to remember this correctly, but I believe that if you have diabetes, your risk of tuberculosis essentially doubles. And if you have tuberculosis, your risk of type 2 diabetes essentially doubles. So there's a vicious cycle going on. Now, in a refugee and emergency context, be aware of the acute emergency situation. So we'll get into diabetic ketoacidosis, but this is a life-threatening emergency, like an emergency in the truest sense. It causes a lot of death. And then also acute hypoglycemia, which you may or may not see so much in emergency context, but that's low blood sugar. Uh, the ABCDEs of diabetes care are A1C for A, so blood glucose optimization, and generally the more normal, i.e., the closer to a non-diabetic profile you can get, the less chance you have of long and short-term complication. The B is for blood pressure control. You generally want to be a little bit more aggressive on the blood pressure control because of the microvascular and macrovascular complications. Cholesterol for C, D for drugs, E for exercising / healthy eating, and then a lot of S's. So screening for complications, so eyes, kidneys, and then also lower limb. Smoking cessation, especially because you're under so much oxidative stress, smoking only harms that, and then self-management, which we're going to talk about. Now, these pictures are actually from Banting and Best, the collaborative University of Toronto over 100 years ago. And for type 1 diabetes, before the discovery of insulin, it was a death sentence. So here you see a young girl before starting insulin therapy and then after starting insulin therapy. So with people with type 1 diabetes will waste away and die without insulin. And actually, this is happening right now in many parts of the world due to the lack of access to insulin. You can look up pictures online, but they're pretty gruesome. But it's more gruesome for the people actually dying. In a clinical setting, in refugee and humanitarian emergency populations, just be aware of diabetic ketoacidosis. So this is generally characterized if someone is undiagnosed by an extremely rapid loss of weight, extreme loss of appetite, extreme thirst. I mean, we're talking like 8 liters, 9 liters of liquids, urination every hour, unable to sleep through the night. And then also there's a characteristic acetone smell. So that is actually acetone on the breath. So if you start seeing all these and the person does not have diabetes, or at least is not able to communicate that, it's probably time for a random blood glucose draw. It doesn't hurt, and at the very least you're going to find out they might have diabetic ketoacidosis, which might kill them. So where do people live with diabetes? Well, they live everywhere. There's 830 million of us. It's hard to believe, but there is actually that many people living with diabetes. And you want to get past this idea that it's a rich person disease. It's very much. So we live everywhere. If you notice the map, I'm going to go back to the map. Can I go back to the map? Sorry, I can't go back to the map with this recording. But your overlay, your heat map of where the prevalences are highest are actually kind of an overlap on where conflict and emergencies are very frequent. So Southeast Asia, Pakistan is one of the most highly prevalent countries for diabetes in the world. Frequent cause of emergencies of flooding, financial instability, political unrest. Syria, before the war, had approximately the same amount of diabetes as United States. But then that's not to say, even very low-income countries don't have people with diabetes. So the organization Santé Diabète started up in Mali, and when they started, people were saying, well, type 1 diabetes is not really a thing here. We've only got the 30 people in Bamako. Well, they've been going for 10 years and there's 30,000 people now. So there's a lot of surveillance bias and people passing away and it just not being recorded. And again, it's not a rich person disease. Most people living with diabetes now live in low and middle income countries. And actually the prevalence in low and middle income countries often surpasses that of Europe. Now, I did my whole thesis on diabetes self-management, so I'm going to try to condense it into a slide. You have to stay within the lines. So if you see that graph, and I'm using my own graph, so I guess I own the rights to this, you have to do your best to try to fit in that green bar. And so for those of you with normally functioning homeostasis, or at least the blood sugar part, normal pancreatic function, your body will naturally stay within the lines. So you'll produce insulin when you get to the above part, so after 8, and you're going to produce glucagon when you're nearing 4, and you're going to naturally kind of stay in there. People with diabetes don't have luxury, so there's a lot of things that we have to do to stay in the middle of that. Regularity of diet. Some people prefer low carb. Insulin therapy if you need insulin. If you don't need, there's oral agents as well. In high-income countries like the United Kingdom, we'd be talking about maybe adjunctive therapy like GLP-1s and SGLT2s. So there's a lot. And when you get diagnosed in a country like the United Kingdom, you basically get like a week of training. And it's a lot of like, well, this is how you do carb counting, and this is how you read a glucometer, and this is how you do finger sticks, and now of course people are getting on to continuous glucose monitoring, and there's about 50 to 100 different factors that will impact your blood sugar at any given time. So, I'm in Marrakesh and it's 40 degrees here today, so I was just out. So I'm noticing a rapid drop from my normal. So heat affects it, sunlight affects it, stress affects it, sleep deprivation affects it. Stress is a major one, especially when we're talking about in emergency and humanitarian context. Stress generally will cause large spikes in blood sugar because of the adrenal system. You're in a stressful environment, your body's dumping sugar through the liver to try to stay alive, but you don't have the capacity to absorb that liver sugar. And you're going to see in places like Palestine and places like Lebanon, people's actual need of insulin is doubling. Ukraine as well. So the ideal state, which is not always possible in these emergency contexts, is a diabetes diagnosis is immediately accompanied by a structured program to provide this education about how you take care of yourself and what complications to look out for. But that's not always possible. And feel free to, you can screenshot any of this or take pictures. I don't mind. Medicine Sans Frontières, the Access campaign has done a lot of interesting stories last year, actually interviewing people who have diabetes about what the interruption of their care was like. And it's hard to put into words how utterly dependent, certainly the type 1 population is on continued access to care. It's higher than something like ART, it's higher than hypertension. If you start missing insulin doses, you will notice immediately. You will start feeling sick immediately. If you go a day or 2 without insulin, you may die. And so it's this absolute need for therapy. And type 2 is generally a little bit different. You have a little bit more leadway, but you very rapidly become sick given access to care interruptions. So if you find yourself as a refugee, you have an immediate problem. You need insulin, like immediately. So if your house has been bombed or there's been an earthquake and you don't have it, you are in trouble. You're in real trouble. So that's a lot of the emergency response around insulin-dependent diabetes. Not just the insulin, though. You need a way to inject insulin. Insulin, at least not yet, is not an oral drug. There's some not weird, but there are some inhalable options, but those are absolutely not in any country except for, I think, the United States and Israel, maybe. So you also need injectables. So you need a safe syringe or insulin pen syringe, and you need a couple of them because they can break. And also, it's just good practice. You don't want to get skin site infection. But with that, you also need food and water. So if you don't have diabetes, you can fast for a while and you're generally going to be okay. If you are on something like insulin therapy or even metformin, some of the orals, you can't really take them and just start fasting. You're going to have a problem. You're going to get into hypoglycemia, and that's also another emergency situation, but you're going to start losing consciousness or your cognition's going to go down. So you need both food and water. And you also need a way to test your blood sugar. So again, staying between the lines. And if you're looking at these sort of contexts, things like a continuous glucose monitor, which I'm wearing on this side, so just these little things. Bought this one in India. Um, you're almost never going to have those in these contexts. I mean, even in India, I think I paid $30 US for this. For it works for 15 days. You know, that's just not going to happen in a place like Sudan. So you're dependent on test strips, and even the test strips, you know, you're not getting many. So you got a couple of different immediate problems, and you need to solve them, or your life is in danger. We talk about the medium-term problems. As you find yourself as a refugee, you generally gonna need to pay for your treatment. You know, you can luck into treatment by international NGO, or if you're finding yourself in a high-income country with a certain benefit plan. I know Canada has actually removed a lot of the refugee area healthcare in the last year or so. So you need money. You know, diabetes, uh, it's not a rich person disease in the sense that poor people are getting it, but it definitely helps be rich. And if you look at the ecosystem, comparing it to say like HIV and AIDS, there's no global fund for diabetes. You know, there's no Gates Foundation for diabetes. It's very much kind of this orphaned disease. So you need to get money. The other thing, refugee diets are generally extremely carb heavy, and so we're talking about like flours, we're talking about starches, because they're cheap. And if you get your diabetes education in a high income country, that's kind of the opposite of what they're going to tell you. They're going to tell you like stock up on protein, stock up on fresh vegetable, and that's just not possible for a lot of the people, which we're going to talk about later on. People with diabetes are very often hypertensive, so there's usually other forms of care that are needed. We mentioned lipids as well. And then the thing is, you're going to find, especially in protracted conflict and emergencies, people actually diagnosed in those emergencies with diabetes, both type 1 and type 2. And as I talked about before, I won't even say gold standard, the minimum standard is like at least a couple of days of good diabetes education. And that is just not possible in a lot of cases. You were looking at extremely busy clinics. Now, it is sometimes possible, and we'll get into some of that later, but it does not mesh very well with being diagnosed with diabetes. Basically, if you want to be diagnosed with diabetes, the best place is probably either the NHS in the UK or Sweden, something like that, not Gaza. And you also need to get to clinic regularly. So especially the international NGOs, for a lot of different reasons, are not going to disperse like 3 months of medicine or 4 months of medicine. And there's a couple of different reasons for that. One, I think they're afraid of reselling and patients rationing, and then if you're in a refugee context, you're usually pretty dire. I know MSF at the time would actually puncture the boxes of some of the medicine so that they couldn't be resold, but they would do it in front of the patients to say like, well, here you go. And that's a fair concern, but then that's also from the patient perspective. You know, if you're a mother with kids and you think you can get away without taking your hypertensive medicine in exchange for a bit of money, you might do it. Long-term problems, you need money. That's not going away. You're also going to need mental health support because there's that double burden of mental health with diabetes. Diabetes makes mental health issues, especially depression, much more likely. You have the preventative screening, and you need to maintain a stable blood glucose in potentially a protracted conflict situation, which is not easy. And then we get into family burden and stigmatization. So stigmatization of people living with diabetes is actually quite common and reported, but you start seeing things like um, women, girls especially, not being put into school, or even family abandonment, and in rare cases, actual homicide. That's been reported in some contexts. But more than that, it's more common. It's more just the feeling of being a burden. Now, about 10 years ago now, I was actually in Lebanon, 2014 and 15, as part of MSF. And that was actually our clinic in Majda Anja, so we had a couple of different clinics, and my job as an epidemiologist was to go around and do a baseline assessment of the existing diabetes education and knowledge. So that's the paper, but you can read it. What we essentially did is we asked 5 questions. We said, how do you know when your blood sugar is low? What do you do about it? How do you know when your blood sugar is high? What do you do about it? And how do you keep things in the middle? And then we had a 0 to 10 score. We found some interesting trends. One was that the patients who were diagnosed pre-civil war in Syria were not that badly educated. It was pretty clear there had been some sort of rudimentary system in place for diabetes education. They weren't getting tens out of tens, but they were generally higher. The people who were diagnosed post-war, during the war, generally were diagnosed by an international NGO or, not in a structured setting. And so your diagnosis is basically like, yeah, we did the blood work, you have diabetes, take this, come back in like a week. And that was problematic. But we also had cases where we had people diagnosed in the war and we had one young man who probably could have been hired just as a diabetes educator, and he just learned everything online on his phone. And he also had a father who had type 1. And this was a person who was working as a farmer, so you can't make assumptions. Now we're in the interesting story time on the topic of don't make assumptions. So as part of my study, we did everything orally. So we had predominantly Arabic speakers. I think we had one or two Kurdish speakers. But we would ask people these questions and demographic questions and everything like that. Also because the population had some literacy problems in Arabic. But we would talk to people, and there was a husband and wife. And I remember they asked, "Oh, could we do it together? Just do our own thing." And well, we said, "Well, we don't want to separate you. That's a good idea, but like, you'll hear each other's answers, and that'll kind of affect the score." So they reluctantly said, "Okay." So we first interviewed the husband, and the husband first was like, "I know everything there is to know about diabetes. My wife is like a great listener. I can always talk to her. It's not a problem." And he got all the answers wrong. He didn't know that much about diabetes. And so we're like, okay, then we bring in the wife. And the wife said, my diabetes is horrible. I don't know anything. I got no one to talk to. And then we asked her the technical questions, like, what do you do in hypoglycemia? She got everything right. She knew everything perfectly. So yeah, you can't assume. And so in a way, there's also like discordancy in the couples as well. But yeah, don't assume is one of the lessons. Uh, some things to know, the WHO has been developing in the last couple of years these non-communicable disease kits, or NCD kits. So these are rapidly deployable kits to emergency and humanitarian settings. There's different modules, but insulin and glucometers, test strips, that's now part of it. And I think they're stored in Dubai. I might be wrong, but it's an innovation basically that providing rapid NCD care. On a positive note, some things have been getting better. So Médecins Sans Frontières in particular, I think has been quite leading in moving forward on some of the more modern elements of care. So pen type devices are being much better used. So there are a couple of different advantages. So I don't know if the mic is going to pick this up, but you can do this. I don't know if you can hear the clicking. But compared to dosing with a syringe, for people with visual problems, it's easier to dose it out by the click. So that's one benefit. It's also much more discreet, which cuts down on stigma and discrimination. There's a lot of advantages to it. There's a slightly higher price than just using syringe, but it's an encouraging thing. You're starting to see a limited use of CGMs in even low-income settings like Sudan, and there's some interesting studies around, could we just give people one sensor a year, spend the $30, and then they can see the pathway. So it's a lot better to calibrate. So that's quite interesting. Some studies coming out on that. A lot of the recent conflicts that have been in the region, so Sudan, Palestine, Lebanon, Iran, diabetes is very much in the conversation, as it should be, because it's a huge amount of the disease burden, and a lot of people living with diabetes live there. I work for something called the Global Diabetes Compact, which was a renewed initiative of the WHO to focus on diabetes. And there's been some high-level meetings. I would say not enough, and not enough, definitely not enough money, but things have been getting a little bit better. What I think needs to change is the major global health funders are still just not funding diabetes. Gates point blank does not fund diabetes, even Avast. Wellcome Trust has no major diabetes funding, Global Fund as well, and a lot of it is around, we don't want to dilute what we're trying to do, but on the other hand, there's almost no money, and it's 830 million people. You need some money, and you need some innovation, you need some attention to this. There's also a lot of stigma and attitudes, and I think just bad practices in the sector that I've noticed. I've seen the diabetes jokes and some of the black humor. It's kind of corrosive. And I think there's also this attitude of once thing is labeled a NCD or non-communicable disease, then it's mixed into a bucket with cancer, hypertension, traffic accidents, oral health, and on and on and on. I mean, even the WHO, the NCD department got merged with mental health, so you have even more dilution. So if you want to talk about a disease affecting 830 million people, you need some attention and money to it, a lot more than there is. And globally, a lot of the modern elements of diabetes care is extremely limited. I mean, it's really poor. So that's the norm, unfortunately, for most of the 830 million people living with this. Uh, you can do this now or later, but this is an interesting thing to type into ChatGPT or Gemini. So what percentage of global health funding is dedicated to diabetes, not including the government funding? So if you type that in, you get a nice explanation. But um, you know, I'm against the clock, so I'll just tell you, it's generally considered to be about 0.5% of all global health funding. Um, Maybe 1% if you look at charitable, if you take the broadest definition of anything that could touch diabetes. Now, if you look at the NHS in the UK, diabetes is about 11% of all the funding, 12% about all the funding. So we need to get a little bit better than 0.5%. I mean, even 2% would be great. But there's a big problem in the sector around diabetes funding. Why is it neglected? I mean, we have the obvious answer, there's no money. Most of the top 10 global health funders don't fund diabetes work, don't consider it a problem. And then you also have, it's complex. You're like, yeah, you got to do insulin, and there's some stuff around cold chain, but I would argue it's a little bit overblown. And then you've got, your test strips and pathways and all that sort of stuff. And the systems are not really designed to take on a new disease, but there's a lot of people living with it. But behind that, I think we have a bigger problem around ignorance of the disease, that diabetes is something that is self-inflicted, that it's something that people don't have to have empathy for. You did to yourself, that things could just be cured with diet and exercise. And if you look at the narrative around HIV in the 80s, you see a lot of the same stuff. Like, oh, it's too expensive, it's really complex, and if only they practiced safe sex and they weren't gay and they didn't use drugs and all that sort of stuff. So there's a lot of that nonsense. Also, the stigma and discrimination element is quite big. There's a lot of people who have diabetes and don't publicly disclose it. So a couple quick experiences. The thing to know in conflict and emergency settings, often there's mixed messaging. So in my VIA diabetes group, we have a WhatsApp, and the messaging from some people in Lebanon was like, everything's cool, there's no problems, and the messaging in other parts of the country were like, I went to the pharmacy and there's nothing. And so you'll find oftentimes the government and the public health officials trying to clamp down on the panic and trying to prevent stockpiling and runs on the pharmacy. So you're going to see some mixed messaging out there. I think the reality was probably in the middle. My own experiences, I was actually in Marrakesh for the 2023 earthquake, and my building thankfully wasn't leveled. But in that moment, it was the first time that myself personally, was in an earthquake and felt the building rumble, and then ran out of the place. But I was thinking, what would happen if my fridge was just crushed and all my insulin was gone? What would I do? I don't know. But it was a rather eye-opening experience. Now, luckily, that didn't happen for me. But if anyone depends on medication to survive, it's not a great experience, and it's not a great state to be in. A couple outdated narratives I think need to go. That the status quo that people in the NHS and people in high-income countries have access to modern insulins, modern injection devices, CGMs. That's a natural state of being because the poor people in these low-income countries, well, who cares? I think that needs to go. I think we need to get to a place where we see HIV and also cancer doing a much better job at equity. I've come across less now, but this whole idea of like, well, even if we had a whole bunch of sensors in Africa, would we even know how to use them? Well, yes. I mean, people got YouTube, and there's lots of TikToks and stuff on how to use stuff, and patient communities are very strong. At the high level, the most frustrating is that let's not work on care. We should all do downstream prevention. Well, we've been talking about that for 50 years, and the diabetes numbers have quadrupled. So that's not working. And also, we're just not going to lifestyle change things like type 1 diabetes away, period. And type 2 diabetes is often driven by colonialism, by destruction of the natural food environment, by health inequality. It's just not going to happen. Another quick one, adults get type 1 diabetes, and younger people can also get type 2 diabetes. It used to be called juvenile diabetes, but now more than half of the diagnoses of type 1 diabetes are now in adults. And also, type 2 diabetes is now being increasingly found in children, especially the obese population. So, get that out of your head. people with type 1 diabetes, also if they're diagnosed as a kid, they get old. Final shout out for a good paper. So this is my colleague Oria James, now at WHO. But you can take a quick screenshot of that, Google it. But a lot of the qualitative work around type 1 diabetes in humanitarian settings is very interesting. A lot of the trade-offs being made are very hard, and there's no easy answers. But it's a good read. Finally, check out a couple of these groups. Voices in Action, that's the group I lead. We're new, but we're trying to put more attention on diabetes in the global health agenda. Médecins Sans Frontières is also doing good work on diabetes. T International, which was started in the UK, very good rights-based charity. I used to be on the board. And then especially for this group, the International Alliance for Diabetes Action, this is specifically a group that was founded at Harvard on the topic of diabetes in humanitarian and emergency settings. So that's it. That's my lecture. Hope you like it, and hope I'm around for the Q&A. I'll probably have a different background. Okay, bye-bye.